today we are very lucky to have Dr. Murphy present to us about reversible dementias. And she will be sharing her insights from her appointment as a clinical neurologist and as a researcher. She did a fellowship with the UCSD Alzheimer's Disease Research Center. So we are very happy to have her present in this forum. And as usual, just if you could put your questions either in the chat or hold them till the end, unless she specifies otherwise, then there's always time at the end for a question and answer period. All right, thank you so much for being here and doing this.
Of course, thank you for having me, and thank you all for accommodating my clinic schedule by showing up on Wednesday instead of Tuesday. All right, so as Christina mentioned, I'm going to speak today about reversible dementias. I have no disclosures. To start with, what do I mean by a reversible dementia? And the term dementia itself refers to a clinical syndrome of cognitive impairment that interferes with daily activities and represents a significant decline from prior level of functioning. The clinical presentation of dementia is diverse. There can be variable involvement of different cognitive domains, including memory, language, executive function, visual spatial function, behavior, etc. And the underlying pathophysiology of dementia is also diverse. When we hear dementia, we tend to think about neurodegenerative disease, which the way things are currently remains an irreversible dementia. And most often, dementia is due to a neurodegenerative disease, Alzheimer's disease being the most common cause. However, there are also a number of different processes, and they are outlined in this table here, spanning metabolic, endocrine, inflammatory, infectious, different exposures, neurosurgical conditions, and others that can cause an irreversible dementia syndrome, or if not irreversible, at least, reversible, or at least partially reversible dementia syndrome. So in this talk, I'm going to review the literature about the prevalence of reversible dementias, discuss the clinical features that might suggest a potentially reversible etiology. I'm going to spend a bit of time looking at the recent literature that suggests that some of these reversible processes might actually be modifiable risk factors in neurodegeneration. And then lastly, I'm going to explore some specific reversible dementia syndromes that are worth noting. So if we look at this from a historical perspective, the 20th century was actually very productive in terms of discovery of reversible dementia syndromes. So starting in the 1920s with the discovery that neurosyphilis, which was previously thought to be an incurable disease, it led to a progressive dementia that would invariably lead to death within a few years. It was found if you inoculated these patients with malaria, it would induce a fever in the patient and would sometimes actually kill the spirochete that was causing the infection in the central nervous system. And this was found to be a successful treatment, and the Nobel Prize was actually awarded for this in 1927. Then in 1930s, Wernicke's encephalopathy was first linked to thiamine deficiency. In the 1940s, neurosyphilis was even more successfully treated with penicillin. And in 1965, it was shown that dementia caused by normal pressure hydrocephalus could be reversed with surgical treatment. So the 20th century was actually so successful, and the medical and scientific communities were on such a roll that there were optimists in the 1970s and 80s that thought we were going to continue in this fashion, and they projected at that point that up to 40% of dementias might actually be reversible. Unfortunately, a 1998 review showed that the prevalence of reversible dementia was actually closer to 10%, And then a 2003 meta-analysis found a similar 9% of dementia cases might have a potentially reversible cause, but of these, less than 1% actually reversed with treatment. Hopefully I will be able to emphasize, though, that although the prevalence of reversible dementia
Musst du der
is low,
Mama sagen. Es ist mir jetzt neu, dass heute Lunch ist. Okay.
Sorry, Johannes, could mute, please. Although the prevalence of reversible dementia is thought to be low, there is a very high relevance of this topic. And if you think about even over the course of one's career, if you were to find a small handful of cases that are fully reversible, the opportunity to really impact those individuals' lives is huge. And then more often the case, what we see clinically is that dementia tends to be a combination of both reversible and irreversible factors. And so very often we see that dementia is due to neurodegeneration, but there are often reversible contributors in these processes. And by addressing these reversible contributors, there is substantial opportunity to improve quality of life. All right, so moving on to clinical features that might suggest a potentially reversible etiology. The American Academy of Neurology recommends screening for certain reversible factors in all dementia cases, so specifically recommends screening for vitamin B12 deficiency, hypothyroidism, and any structural abnormalities. However, there are certain clinical features that should make the clinician pause and consider further workup for additional reversible etiologies. And these clinical features are essentially features that would be considered abnormal in neurodegenerative disease. And so it would be considered abnormal to have an acute onset of cognitive dysfunction, if there's any rapid deterioration, if this is occurring at a younger than expected age, if there are prominent fluctuations over the course of the disease, if the patient has any high risk exposures in their history, certainly if you find any focal findings on the neurologic exam, and then if there is an incongruence between what a patient is telling you in terms of how they're functioning in day-to-day life and how they perform on neurocognitive testing. Oh, and of note, there was a really nice article in the Continuum, it's referenced here last year, that is worth reading, that reports case reports for each of these clinical features, showing how it was it is linked to reversible dementia. So moving on, there's one area that really interests me is that there's been a paradigm shift as some of the processes that are classically thought to be fully reversible have actually recently been implicated in irreversible neurodegeneration. And specifically, exposure to certain medications, sleep dysfunction, and depression have been shown to possibly play a role in Alzheimer's disease pathogenesis. It was previously hypothesized that the impairment caused by these entities was transient and fully reversible and independent, although often occurring concomitantly with neurodegeneration. But there is accumulating evidence that supports a more direct association. And this is critical because then by addressing these factors, treatment not only has the potential to reverse any direct effect that they may be having on cognition, but it might also mitigate downstream neurodegeneration. So in this way, these reversible factors can be thought of with a new relevance as a modifiable target potentially in neurodegenerative disease. So we'll start with the literature about exposure to anticholinergic medications. And again, this was traditionally thought to only cause a transient and reversible impairment. However, more recently, exposure to anticholinergic medications has been linked to an increased risk of both all-cause dementia and Alzheimer's disease. There was a 2015 prospective cohort study of over 3,400 adults, and this showed adjusted hazard ratios of 1.65 for all-cause dementia and 1.94 for Alzheimer's disease. There was a dose response here with higher cumulative anticholinergic exposure associating with a higher risk. The most commonly used anticholinergic medications reported in this study were medications that we see very often in clinic, including bladder antimuscarinics. Very often we see elderly patients come to us, especially older women with issues with urinary frequency and urgency, and they are on oxybutynin. Tricyclic antidepressants, also very commonly used, especially by neurologists for headache treatment, and also first-generation antihistamines like Benadryl. This issue really became widespread mainstream knowledge when it hit the news in 2019, when a case control study showed that this was more or almost 300,000 older adults. And it showed that if you take a single strong anticholinergic medication daily for 3 years, that confers a 50% increased odds of dementia. Similarly, the data on obstructive sleep apnea, this again has long been recognized as an important cause of cognitive impairment, but there's been recent attention on the potential role of sleep disturbance in Alzheimer's disease pathogenesis. So prospective cohort studies of incident dementia have shown that people with sleep complaints in middle age are associated with an increased risk of developing Alzheimer's disease. And meta-analyses have confirmed the potential role for sleep disorders as predictors of Alzheimer's disease pathology. At least 2 recent studies have shown that sleep disruption increases soluble A-beta in CSF, which suggest a potential mechanism as to how this might be increasing risk of AD. And the link between OSA and Alzheimer's disease is further supported by treatment trials. There was a large randomized controlled trial that showed if in patients with both Alzheimer's disease and obstructive sleep apnea, if they're treated with CPAP, there's significant improvement of executive function. A smaller randomized controlled study, again in patients with both Alzheimer's disease and OSA, showed that CPAP treatment improved verbal learning, memory, and executive function. And then a more recent 3-year pilot study showed that 80 patients with OSA who were in the CPAP treatment arm had significantly slower cognitive decline than subjects with Alzheimer's disease and OSA who were not treated with CPAP. Similarly, there's an expanding body of literature on the association between depression and Alzheimer's disease. It's commonly known that depression often accompanies Alzheimer's disease, even in patients who have no prior history of depression prior to the onset of Alzheimer's disease. But several studies have also shown that depression symptoms associate with changes in Alzheimer's disease biomarkers. There was a 2019 longitudinal study that showed that worsening depression symptoms significantly associated with cognitive decline in patients who were cognitively normal at baseline, but were amyloid positive by PET at baseline. And the authors of this study proposed a model by which cortical amyloid might underlie both depression and cognitive decline in Alzheimer's disease. However, it's important to note that a causal association has not been demonstrated, and it remains unclear whether treatment of depression symptoms might improve cognitive impairment due to amyloid burden. And then lastly, there was a very recent article in July 2020, this year, in JAMA, that proposed a new disease model for Alzheimer's disease by which neurotropic viruses might induce chronic inflammation in the brain that might also contribute to Alzheimer's disease pathogenesis. There have been multiple epidemiological studies that have reported an association specifically between herpes simplex virus type 1 infection and Alzheimer's disease. And in vitro studies that have demonstrated that HSV-1 infection can actually lead to an accumulation of amyloid beta and tau. And in vitro, at least, the accumulation appears to be reversible with treatment with acyclovir. However, whether acyclovir treatment might have any impact on preventing or even reversing Alzheimer's disease pathology in vivo has not yet been demonstrated. All right, so I'm going to spend the bulk of the time exploring specific reversible dementia syndromes. So it's important to keep in mind that the factors that we've already discussed, exposure to anticholinergic medications, sleep dysfunction, depression, these are very common factors in the patients that we see, and all of our patients should be evaluated for these issues. Now, when we get into more specific and rare reversible dementia syndromes, these are not appropriate to evaluate all patients for, but I will try to point out which patients might be appropriate to screen for these specific syndromes. So to start with vitamin B12 deficiency, as I mentioned before, the American Academy of Neurology does actually recommend screening for vitamin B12 deficiency in all dementia cases, and this is largely based on prevalence data that vitamin B12 deficiency is very common in the elderly. Despite this, though, it's actually thought to be a rather uncommon cause of reversible dementia. One study I found it's thought to account for only 1% of reversible cases. Risk factors for vitamin B12 deficiency include just simply being older over the age of 75, and then anything else that might impair the absorption of vitamin B12 in the GI tract. So certainly if anyone has a gastrointestinal disease such as Crohn's, Whipple's, celiac, etc., or if anyone has had any gastrointestinal surgeries, they are at increased risk for a vitamin B12 deficiency. The question of reversibility in vitamin B12 deficiency in dementia due to vitamin B12 deficiency is still controversial. There is evidence that correction of the deficiency may improve mild cognitive impairment, and there's data supporting the improvement specifically of verbal fluency when treating vitamin B12 deficiency, but it actually remains unknown whether a true dementia due to vitamin B12 deficiency is fully reversible. Other neurologic manifestations in vitamin B12 deficiency include acroparesthesia, so burning, tingling sensation in the hands and feet, a loss of position and vibratory sense, and then it can also be associated with an optic neuropathy. Autoimmune dementia, this became a hot topic in 2007 when Joseph Dalmau, he is here on the left, he is a Spanish physician who is currently at the University of Pennsylvania. He was originally trained as a neuro-oncologist, and he, in 2007, discovered anti-NMDA receptor encephalitis. And that was really the first of autoantibodies directed at the central nervous system to be discovered. Since then, he and others have gone on to discover a number of other autoantibodies directed at CNS targets. But anti-NMDA receptor encephalitis was really the first. And it became, again, public knowledge when journalist Susanna Cahalan wrote about her own personal experience with anti-NMDA receptor encephalitis in this memoir titled Brain on Fire. I think it's subsequently been converted into a movie. So in autoimmune dementia, this includes anti-NMDA receptor encephalitis, but also includes many other autoantibodies directed against CNS targets. You tend to see a fluctuating or a rapidly progressive course. It's typically associated with other neurologic features such as new onset seizures, but of note, cognitive dysfunction can occur in isolation in autoimmune dementia, especially early in the disease course. So you might not always see those other features. The cognitive dysfunction does tend to develop over days to weeks, and as I mentioned, a fluctuating or rapidly progressive course. And autoimmune etiology really should be considered anytime you see an acute or subacute evolution, especially in a younger patient, if there's any presence of seizure or focal findings on neurologic exam, and especially if there's any precedent viral prodrome or immunological challenge. there should be a diagnostic workup for a potential autoimmune dementia. Really the mainstay in the workup here is a lumbar puncture. Very often the CSF will show a pleocytosis. And then you may or may not be able to detect the antibody in the CSF. Obviously, it's the gold standard for diagnosis if you're able to find the actual antibody. And there's a number of panels now that you can send off the CSF to test for the known antibodies that have CNS targets. But it's worth noting that there are presumably any number of antibodies with CNS targets that are not yet known to us. And so if an antibody is not detected on CSF, that does not exclude this diagnosis. MRI may or may not be helpful. Sometimes you see T2 or flare hyperintensities that may or may not enhance with gadolinium. And if clinical suspicion is high enough for an autoimmune dementia, it's reasonable to try empiric treatment. The treatment in this condition really aims at immunosuppression. So first line would be intravenous high-dose steroids, and then IVIG and Plex are also used. Hashimoto encephalopathy is also an autoimmune dementia. If you're not a fan of eponyms, it's also called steroid responsive encephalopathy associated with autoimmune thyroiditis. It's quite the name. It's a rare syndrome and its pathophysiology is really poorly understood. Patients are predominantly female and the highest incidence is in the 5th and 6th decades. Clinical presentation is variable, but it often involves confusion and behavioral changes. You may also see seizures, ataxia, myoclonus. Symptoms may be episodic or progressive, and unfortunately, there are cases of Hashimoto encephalopathy presenting as a more subacute onset, subacute course with a very insidious onset. And so this can mimic a neurodegenerative condition. One thing that is often misunderstood about this condition is that the majority of patients are euthyroid. So if you are just trying to screen for Hashimoto encephalopathy by checking your thyroid function test, your TSH, and your free type T4, you are not going to pick up this condition. Diagnostic evaluation actually depends on elevations of one of two antibodies, antithyroid globulin or antithyroid peroxidase. But your TSH and your free T4 tend to be normal in this condition. And then as mentioned in the non-eponym title, most patients do respond very well to corticosteroids in Hashimoto encephalopathy, although sometimes other immunosuppressive medications are needed. Neurosyphilis, I mentioned this a bit when we were discussing the advances in the 20th century in the treatment of reversible dementia. So prior to the 1920s, neurosyphilis, it's also called general paresis or dementia paralytica. It was a universally fatal, progressive dementing illness that would lead to death within a few years. It's caused by infection of the spirochete treponema pallidum in the central nervous system. And it can occur at any time after the initial infection, although it's not actually thought to cause a dementia syndrome until at least 10 years after the initial infection. So it's considered a tertiary stage of syphilis. Despite the widespread use of penicillin around the world, the global prevalence of syphilis is actually increasing. So this is a condition that we need to maintain awareness of. HIV is often a co-infection with syphilis. The clinical presentation, very often these patients present with psychosis, stuttering speech, depression, delusions of grandeur. Other common neurologic signs include dysarthria, intention tremors of the face and tongue. You can have low tone in both your face and your limbs. This is the facial and appendicular hypotonia. You can also have pupillary abnormalities. Without treatment, again, it leads to death within a few years, but this is treatable with penicillin. And if it works, they have a video here for you. So this is called the candy sign. This is a pathognomonic feature of neurosyphilis, but it is not often seen. This video that I'm going to show you is a 45-year-old gentleman who presented with a rapidly progressive cognitive decline in behavioral symptoms, and he was found to have evidence of neurosyphilis. And this video is highlighting these really abnormal facial movements. It consists of a non-rhythmic brief contraction of his orofacial muscles. It's a rare dyskinesia, and again, it's considered pathognomonic of neurosyphilis, but is not always seen. There's no video or no audio with the sound, but you can just appreciate these abnormal movements. That's called the candy sign because it looks a little bit like he's chewing on a piece of candy. All right. So moving on to Whipple's disease. Whipple's disease is a rare systemic disease. It's caused by infection with a gram-positive bacillus Tripherma whipplei, and it can cause a progressive cognitive decline that, again, unfortunately, can mimic neurodegenerative disease. And so this is something that should be suspected in any patients that present with these other classical features, which include joint pains, weight loss, diarrhea, or abdominal pain. Other neurologic findings in this condition include a supranuclear ophthalmoplegia, pendular nystagmus, and I have a video to show you those features as well, myoclonus, and then this oculomasticatory myarrhythmia, which is considered pathognomonic, but is not always present. And I have a video to show you what that looks like as well. When you do labs in these patients, you might get some features that suggest malabsorption with low albumin and vitamin deficiencies. You may have a very nonspecific elevation and acute phase reactants. MRI can also be very nonspecific. It can be completely normal in Whipple's disease. It can show a focal lesion. It can show a multifocal lesion, very often involving the mesial temporal lobe, midbrain, hypothalamus, or thalamus. You can also see a periventricular diffuse leucopathy. You can see diffuse cortical atrophy. You can see a pachymeningitis. So really the MRI can essentially show you anything. If you are suspicious of this disease, the gold standard diagnosis is made by finding this bacillus in the small intestine tissue, and then confirmatory testing in the central nervous system with lumbar puncture. And treatment is with IV antibiotics. So this is a little video here of a patient with Whipple's disease.
This patient was under the care of John Selhorst with CNS Whipple's disease. The eyes are showing constant pendular vergence oscillations. These are synchronous with concurrent contractions of the masticatory muscles, which are moving his jaw. Hence the title, oculomasticatory myarrhythmia. The third feature is a supranuclear vertical gaze palsy. See these striking pendular vergence movements. The pupils are normal. He doesn't look down well, and he has a paralysis of upgaze. He can purse his lips and somewhat stop the movement of the jaws. Vertical ocular cephalic reflexes are normal. The eyes move fully. Whipple's disease is due to an infection with the Bacillus Whippelli, an illness that can be treated. And we see here he's doing quite well. I find it hard to see any abnormal oscillations of the eyes.
All right, so we'll stop that there. So just highlighting again that some of these syndromes are very treatable. Success story there. Moving on to normal pressure hydrocephalus. So in 1965, I mentioned this in the timeline as well, there was a Colombian physician named Hakim. And then this is his mentor at Mass Gen Hospital, Adams. And the two of them together showed that normal pressure hydrocephalus could, the dementia caused by this could be reversed by surgical treatments. The classical clinical trial in triad in NPH involves the most common and earliest symptom being a gait disturbance. And I wish I had a video of this. I should have put in a video. There's a very specific gait associated with NPH. It's called a magnetic gait. It looks a little bit like someone's feet are stuck to the ground, like they have. It's also been described as having your feet in water skis, kind of moving along the surface of the floor. I apologize, I should have put in a video for that. But that tends to be the earliest and most common feature, and then followed by cognitive impairment, and then urinary issues, including urgency and frequency. The pathophysiology of NPH is not fully understood. It's thought to be due to some impairment in CSF flow or some derangement in the CSF biochemistry and cerebrovascular compromise. We rely very heavily on the radiographic findings in normal pressure hydrocephalus. So it's not just having big ventricles that by itself, ventriculomegaly can be due to a number of other causes. One of the most common that we see is just ex vacuo dilatation of the ventricles in neurodegenerative disease. If you lose enough brain volume, your ventricles get bigger to account for that space. So there are several other radiographic features that to this being due to normal pressure hydrocephalus rather than just ex vacuo dilatation. There are some objective measures such as the Evans index, and that is where you take the ratio of the largest width of the frontal horn to the widest measure of the inner table of the skull at that level. And then there's also this feature called DESH, which stands for disproportionately enlarged subarachnoid space hydrocephalus. This diagnosis is very often raised, the possibility of the diagnosis is often raised by a radiologist. And it's important to note that all three clinical features might not be present. And so if there are radiologic findings that are suggestive of normal pressure hydrocephalus, and there are some clinical features that are consistent, then it's, I think, worth doing a workup for this. And the workup includes a large volume lumbar puncture. And by large volume, this should be ideally 30, 40, 50 cc's even. And pre and post gait and cognitive testing. So there are very specific gait challenges that have been published in the literature. One of them is the Get Up and Go challenge, where you have someone stand up, turn, walk, and sit back down, and you time that, and you do it several times, both before the lumbar puncture and after the lumbar puncture. And then you can also do some cognitive testing, measures of attention and focus. You can do cognitive screens such as the MMSE or the MoCA before and afterward. And the idea here is that if you see improvement in gait or in the cognitive impairment after the lumbar puncture, after you've removed that fluid, it suggests that the patient might be responsive to shunting. So shunting it's not a benign procedure, it's a neurosurgical procedure. There is a relatively high rate of complication with shunting. Shunt infections are a real risk here, and so it's you want to evaluate carefully whether or not you think your patient might actually be responsive to shunting before sending them for this neurosurgical procedure. But if the patient is responsive to the high volume lumbar puncture, then there's a good chance that shunting might actually be very helpful, and there is again a substantial opportunity to improve someone's quality of life with this procedure. And then transient epileptic amnesia, this might be my favorite cause of reversible dementia. This is also a very rare syndrome. It's not well understood and it's not well recognized. It's very often underdiagnosed, misdiagnosed entirely, especially if there are no overt signs of seizure activity in these patients. So this is TEA is thought to be a subtype of temporal lobe epilepsy involving the bilateral mesial temporal lobes. So just as a reminder, a seizure is any abnormal synchronous electrical activity in the brain. We tend to think of seizures as the what we see in movies, the grand mal or generalized tonic-clonic seizure where someone falls to the ground and their whole body is shaking rhythmically. That is when there is abnormal synchronous activity across the bilateral cortex. But you can have a seizure, you can have this abnormal electrical activity in any small part of the brain. And in TEA, it's thought to occur in just the bilateral mesial temporal lobes. And so as you can imagine, the seizures present as isolated memory loss. And this memory loss can be anterograde, retrograde, or both. One of the keys to this being seizures is that these episodes are recurrent and they tend to be stereotyped. The episodes generally last less than 1 hour. They very often occur upon waking, and the patients tend to have either partial or complete amnesia for the event. Very often patients, I believe 2/3 of patients with transient epileptic amnesia have other seizure types as well, and a common seizure type that occurs concomitantly with TEA is olfactory hallucinatory seizures. Additionally, TEA is, it's interestingly associated with 2 specific forms of interictal, meaning between seizures, memory impairment. One of them is a loss of newly acquired memory over days to weeks. And then secondly, it can be associated with an autobiographical amnesia. And so in general, these patients between seizures, they tend to be fairly normal, although they can have these forms of interictal memory impairment, and this can actually be progressive as well. So again, sometimes a little bit difficult to distinguish, to differentiate from a neurodegenerative disease. Confounding the picture is that your routine EEG in these cases is not going to be helpful. First of all, a routine EEG very often does not capture a seizure when these seizures are occurring infrequently. A routine EEG is typically just a 30-minute study. But even if you were to get an EEG onto someone in during a seizure, the fact that the seizure focus here is thought to be their bilateral mesial temporal lobes, that's a very deep focus. And so it might not be the case that a surface or a scalp electrode would be able to detect abnormal electrical activity that's going on so deep within the brain. So the routine EEG is very often normal. When it's not normal, the most common finding in this condition is just a non-specific slowing that we never really know what to make much of. MRI can actually show some mild atrophy in the bilateral hippocampi, which again does not help us when we're trying to differentiate between a neurodegenerative disease. Given the diagnostic challenge of this, if there's a reasonable clinical suspicion, it's reasonable to empirically try an anti-epileptic drug to see if this offers someone improvement. And if the memory impairment is due to TEA, the seizures typically respond very well to the AED. And so you tend to get a report that they're no longer having these episodes of severe memory loss. However, the interictal memory impairment that we discussed may actually be irreversible and not responsive to the anti-epileptic drugs. And then I believe this is my last specific syndrome that I'm going to speak about. And this is a really interesting one. So there have been a few case reports of corticobasal syndrome being caused by internal carotid artery occlusion. So these patients in the case reports presented with all the classical features of corticobasal syndrome. So this includes a cognitive dysfunction, a unilateral limb kinetic apraxia, extrapyramidal symptoms. And the MRI in these cases showed the classical asymmetric atrophy that you expect in the characteristic corticobasal syndrome due to neurodegenerative cause. However, vessel imaging in these cases showed an ipsilateral occlusion of the ICA. The incidence of this being the origin of corticobasal syndrome is really not known, and there is no good guidance that I can find, at least in the literature, as to when we should be considering obtaining vessel imaging in patients who present with clinical and radiographic features of CBS, but certainly something to consider. And then further confounding the picture is that there are also case reports of a internal carotid artery occlusion causing other syndromes as well, mimicking neurodegenerative disease. Specifically, there's a case report of a frontal dysexecutive syndrome with left frontotemporal atrophy that, for all intents and purposes, looks like behavioral variant FTD, that it was actually been found to be caused by an ICA occlusion. So these are images from a 2013 case report that described a 65-year-old gentleman who developed progressive worsening of right-sided limb kinetic apraxia, extrapyramidal dysfunction, suggestive of corticobasal syndrome. You see here that he has the atrophy that looks like a neurodegenerative cause, but then he was found to have this occlusion of his ICA that was causing this general atrophy and decreased cerebral blood flow to the left hemisphere. So in conclusion, it is rare to encounter a fully reversible dementia syndrome. However, the opportunity to offer a cure in these rare cases of a fully reversible dementia syndrome necessitates clinical awareness. And the presence of certain atypical clinical features in dementia should trigger additional evaluation for a reversible cause beyond what is just recommended in the screen by the American Academy of Neurology. And then more often the case, even in patients who present with the classical features of neurodegenerative disease, it can be a textbook case of Alzheimer's disease. The clinician should always be evaluating for any potentially reversible contributors, most notably depression, sleep apnea, exposure to anticholinergic medications. And although for now neurodegenerative disease remains irreversible, there is really substantial opportunity to improve outcomes by addressing these reversible factors. So that's all I have. I'd like to acknowledge Dr. Leger and Dr. Peters, who helped me research this topic. And if you're interested, we have a review that will be published soon in Current Treatment Options in Neurology discussing reversible dementias. And we have time for questions.
That was great. That was a really excellent presentation. Thank you so much. I do have one in the chat. If other people want to submit in the chat, please do. Or if you'd rather just hop in and ask directly, that's completely fine. So the first question that was submitted asked, what does it mean to have focal neurological findings? This was mentioned as being relevant to several of the reversible dementias.
Got it. Great question. So focal neurologic finding is essentially when we do our neurologic exam, if anything comes up to be abnormal on the exam. So we're looking at cranial nerve functions, we look at eye movements, we look at the how the face is moving, we look at strength throughout the body, we look at sensation throughout the body. So if we see anything that suggests there is, by focal, we mean a single lesion. So anything that suggests there's a single lesion somewhere in the nervous system, whether it's in the brain or in the spinal cord. So if you have a weakness in one part of the body, if you have a sensory loss in some part of the body, if you have any abnormalities in your cranial nerves, that would all suggest that there might be, in clinician speak, we call it a focal lesion, which essentially lesion just means a problem It's non-specific to underlying etiology, so it doesn't tell you anything about the cause of that problem. It just means there's a problem, and focal meaning there's a single problem somewhere. So anything on your exam that suggests there's a single problem somewhere in the neurologic system in the brain or the spinal cord or in the peripheral nervous system. Does that answer the question?
Yes, thank you.
I don't have any other submitted questions in the chat. So if anybody else has a question they'd like to just unmute themselves and ask, please feel free to do so.
I do have a second question if nobody else has one. For the transient epileptic amnesia, you mentioned autobiographical memory loss. Has anyone looked at whether the memory loss for the past applies to non-autobiographical memory, like semantic memory?
I don't know. I don't know the answer to that. I'm not sure whether it's been looked at or not. I know the one that's well characterized in the syndrome is the autobiographical, but I'm not sure if it's just hasn't been studied or if it hasn't been found.
Got it. Thank you.
I have a question. I was just wondering, when you see somebody clinically, it seems kind of overwhelming to think of so many things that might be going wrong, and you could probably get some clues about it from certain symptoms. But what is that like? Do you have sort of a list that you go down?
Is there a list? Yes, I mean, I think as clinicians in our head, we generally have a process that we tend to follow. And I think as we're taking the clinical history, we spend quite a bit of time in these patients taking a really thorough clinical history. And I think a lot of clinical practice of medicine is pattern recognition. So as we're taking the clinical history, as if we start to hear things that are red flags or a little bit atypical, I think that tends to trigger us to think more about these other rare entities. One of the advantages in neurology, advantage or disadvantage, is that our workup is actually, there are only so many diagnostic evaluations we can do. I guess there's probably an endless number of blood tests that we can check, but otherwise our toolbox, we have various imaging modalities. We can evaluate the CSF, and then we can look at the electrical activity in the brain. Beyond that, there are some rarer things that occasionally we will go to brain biopsy and that sort of thing. But I think anytime that we are triggered that our pattern recognition is not quite fitting, we tend to reach for those diagnostic tools. But I guess that's a process. I don't know if Dr. Leger he's been in this much longer than me, can speak to it more about how he approaches it.
I think that, first of all, thanks, Liz. That was a great presentation. I look forward to the paper coming out. I think, your summary is really good in that as physicians that see patients with dementing disorders, we're used to seeing a pattern. We understand how these disorders should behave. So if we see partial behavior or things that diverge from what we expect, then we start questioning that particular diagnosis and start looking for other things. So, Alzheimer's disease, although it can present in somebody in their 30s or 40s, we're kind of uncomfortable making that diagnosis without doing a little bit more work. Focal findings on examination. Again, Alzheimer's disease should have a very non-focal, very normal neurological exam, in fact. So when we find abnormalities, asymmetries, apraxia that shouldn't be there early on, then we start worrying about other factors, other causes.
Thank you.
It is pattern recognition, or recognition that it's not following the pattern that we expect.
Thank you. I see a few more questions in the chat. Examples of over-the-counter drugs that are anticholinergic. So one of the most common here, first generation antihistamine. So Benadryl is probably the most common of those. And the second and third generation antihistamines, things like Claritin, Zyrtec, Allegra are not considered to be strongly anticholinergic. I think Benadryl is the one that comes to mind there. And any insomnia treatment that you can recommend? Well, yes. So first of all, I think it's an important in evaluating sleep that we do so in a formal way. And so if there's any concern about sleep dysfunction, we tend to refer to our sleep clinician colleagues, and they can do a formal diagnostic sleep study to evaluate for most commonly what we find is obstructive sleep apnea in our clinic. So I think rather than just trying to treat a sleep dysfunction, it's always important to first do a good diagnostic evaluation. And then in terms of a treatment beyond treatments for sleep apnea, just treatments to try to help people sleep, most commonly we try to start with melatonin. It's a pretty gentle over-the-counter natural supplement. The key to melatonin is we recommend that people take it regularly at the same time every night. It should not be a medication that's just taken as needed, because it, if you take it religiously, it helps regulate your circadian rhythm. So that's very often a starting point for us. And then we also have other medications. Another one that we use pretty commonly in this population that has helps with insomnia and also helps with increasing appetite and helps a bit with mood is mirtazapine or Remeron, which is an antidepressant, but can be very useful to help with sleep. And let's see.
I'll say that our first maneuver to help with sleep is to encourage patients to exercise.
Yes, so yeah, I forgot about the non-pharmacologic measures. So certainly exercise, good sleep hygiene. We very often counsel patients on sleep hygiene. One of Dr. Legere's favorite is removing any pets from the bedroom. But things like keeping the room dark, cool, avoiding screen time before bedtime, all of that, certainly starting with those non-pharmacologic measures. I see a question here. When do you suspect that CBD, corticobasal or degeneration may not be a degenerative cause? So just a little bit of nomenclature there. So corticobasal degeneration refers to a specific pathology due to a degenerative cause. So that's why we are now using the term corticobasal syndrome to refer to the clinical syndrome when we don't have a pathologic diagnosis yet. That's a great question, and I've been reading about this, and I don't actually have a good answer for myself as to when someone presents with corticobasal syndrome, when do we need to look for specifically this potential vaso-occlusive disease. I think now that I'm aware of these case reports, I will probably tend toward caution and just get vessel imaging in patients that present. But I don't know. From what I read of these case reports, there aren't actually features in these cases that would suggest it was not due to a degenerative cause. Certainly, vascular risk factors would increase one's suspicion of vaso-occlusive disease, but vascular risk factors are exceedingly common in the patients that we see. So maybe if someone has absolutely no vascular risk factors, you would think more likely degenerative disease, and you might not do vessel imaging in that patient. But I think otherwise, in someone who presents with corticobasal syndrome and has vascular risk factors, it's something certainly to consider.
We gave this a lot of thought when the paper was written, and we were a little bit surprised at this particular condition. We don't think of neurodegenerative diseases without clear vascular disease involved, that, oh, this must be a vaso-occlusive disease. So we're very surprised, and we're struggling with how to approach this going forward. We don't typically do vessel imaging in our patients. In fact, we almost never do vessel imaging unless there's a reason for that. There are two things, I guess, that we might think of, though, and one is that if there's a little bit more white matter disease or what looks like watershed damage in that side of the brain, that might lead us to think, well, maybe that carotid is not as effective as the other side. And the other, and Liz, I don't think we talked about this, but the other might be whether we could start asking for a blood flow study within the MRI to see if there's any reduction in blood flow. I don't know that that's been done. I don't know that the papers that we saw, I don't recall that the papers that we saw did that, but it is a scan that can be added to the usual sequences, and that might help us make decisions going forward.
Yeah, I know that was done in at least one of the case reports I saw. And I think that's what actually triggered the vessel imaging in that case, was that they saw severely decreased cerebral blood flow on MRI to the region.
So we could modify our memory protocol to include a cerebral blood flow sequence. Might even save a few PET scans.
Yeah, sure. 4-man's PET scan.
Yeah.
I see a question here about antibiotics with anticholinergic side effects, particularly as a treatment for COVID-19. I am not aware of antibiotics with anticholinergic side effects. I don't know, Dr. Leger, if you are. Doesn't come to mind as any.
Not per se. And I would say antibiotics tend to be used for short periods of time, not for extended periods. So even if they did have anticholinergic side effects, I would maybe allow them if they're the antibiotic that you need. But I can't think of any that are known to have significant anticholinergic effects. I think one of the major culprits for us are medications like Benadryl. You know, and Benadryl is part of the PM component of all PM medications, whether it's Tylenol PM or Advil PM or this or that. They throw in Benadryl because it's an anticholinergic and it makes you sleepy. So I think we're often taking patients off of that. Patients with a sleep disorder that are taking that instead of exercising.
Hey, Dr. Ravi, can I ask a question?
Sure, go ahead.
Great talk, by the way, Dr. Ravi. I just wanted to ask, I know that functional diagnoses are kind of at the back burner, but in a transient epileptic amnesia, and you're not seeing anybody EEG, how do you kind of differentiate between like a functional non-epileptic seizure diagnosis versus the transient epileptic amnesia?
So I'm having a little bit of difficulty hearing you, but I think the question is, how do you distinguish between a functional cause, meaning non-physiologic, perhaps psychologic cause of memory impairment versus transient epileptic amnesia? Is that the question?
Yes, pretty much. Thank you.
Okay. Great question. This is a question I think that plagues all fields of neurology. You know, every clinician has their own approach to the question of how do you determine whether something is functional or not. I think as a young clinician, I tend to assume that things are not functional until I have very, very strong evidence and have done a full diagnostic evaluation, and that has all come up unrevealing. So I think I just have a personal bias that I tend to not assume things are functional until I'm really presented with overwhelming evidence in terms of all diagnostic studies being normal. In the case specifically for TEA versus you know, a functional, I think in that case, my own approach would be just to go ahead and start the anti-epileptic in the case that it might actually be epileptic in nature rather than non-epileptic in nature. And that's, you know, the risk of starting an anti-epileptic medicine are relatively low. These are generally well-tolerated medications. So it's, you're not taking a huge risk by starting it. And if there's improvement with the anti-epileptic medication, then it's either due to an epileptic cause or you have a placebo effect. Either way, you've caused some improvement in the quality of life. So I think that would be my own approach to it. I think it's important for us to keep in mind that as we discover more and more in the field of neurology and at the crossroads between neurology and psychiatry, people who were once diagnosed with functional disorders, we have subsequently found a neurologic cause for some of those disorders. Certainly functional disorders exist. How often they exist, we really don't know. And so I think our role as a clinician is to assume things are not functional and really do a full workup. But again, that's my personal bias and approach.
Can I comment?
Yes, please.
Absolutely, everything you said is absolutely right. That we're always struck with, could this be functional? And sometimes we get angry. You know, we have this kind of counter-transference when we meet somebody who we think is faking it, or who has not necessarily a functional disorder, but a factitious disorder. It's very annoying to the clinician, but we need to make sure that we're not missing something. And so we always go through the paces every time. Not every time, but at least initially we go through the paces. Sometimes there are people who, and I think it was part of the criteria for worrying about, is this standard stuff or not? But you had as one of the criteria incongruence between functional impairment and cognitive impairment. And I think that also often represents or can set a red flag for functional impairment, a functional or factitious disorder. And the neuropsychologists are actually pretty good at picking up some of these things with validity testing. So they can monitor how much effort somebody puts into a particular test and decide whether their performance is normal or has been enhanced or embellished in some way, or their poor performance has been embellished in some way. We're always reminded that the people who suffer most frequently from pseudo seizures, the people who suffer from functional seizures, are people who suffer from real seizures. So the appearance of a cognitive deficit or the appearance of a neurologic deficit of some sort is much more frequent in somebody who actually does have an underlying condition that may or may not have been detected yet. So again, it behooves us to make sure that we really understand as best we can this particular patient. And finally, whether this is functional or not, these are patients who suffer. There's something going on with them that's led them to have this functional disorder. And although as neurologists, we don't have all of the tools to deal with that, I think working, as you pointed out, working in concert with our psychiatry friends, we can help these people. And simply saying, oh, this isn't neurological and not moving forward from there is a disservice to them.
Well put. There's another question specifically about the study with sleep apnea in patients who were treated with CPAP, patients with AD and OSA. So this was a French prospective study that was done in was published in 2014, and they were looking at cognitive decline as measured by MMSE. And they did a 3-year follow-up. And in the patients who were treated with CPAP, the main MMSE decline was 0.7 points on the MMSE. So the MMSE is on a 30-point scale over 3 years. And the non-CPAP group declined by an average of 2.2 on the MMSE. So. Another question, any progression or upcoming drug to reverse dementia? I assume you're speaking probably about neurodegenerative dementia or Alzheimer's disease there. And yeah, upcoming Alzheimer's, okay. Yes, potentially. I know there is one right now that's under review from the FDA, aducanumab, and I believe the DUFA is March 2021, so we should probably have an answer within the next 6 months or so, whether or not that's going to be an FDA approved treatment. And the idea there is that it might be at least help with partially reversing early Alzheimer's. I think there are several others in the pipeline, but nothing that is FDA approved as of today.
Aducanumab is an infusion drug. It's been given for many months to patients that were in the trial. We have no idea how long we have to give it for, whether we can give it for a little bit, let the patients go away, come bring them back and do it again. We have no idea who's going to pay for it. We're talking about probably $20,000 a year for this treatment. And we don't know what the long-term consequences are either. So it's going to be a mess when this medication, if it gets approved. It's going to create quite a mess, both in terms of how we treat our patients and how we find new drugs to treat patients with Alzheimer's disease, because many patients might end up with this drug and that will interfere with our understanding of other drugs. It's going to be an interesting couple of years coming up. But we're excited.
Well, that's great. I think we are at time, and I don't see anything else new except other people complimenting your excellent presentation and presentation style, which I have to endorse as well. So thank you so very much for taking the time to prepare this and deliver it. And thank you, Dr. Legere, also for piping in and helping with the Q&A.